Good afternoon, everyone, and welcome. Thank you for joining us today. I'm José Ramón Paño, infectious disease physician at Hospital Clínico Universitario in Zaragoza, Spain, and I'll be moderating today's session. I co-lead task 6.4 of the EU JAMRAI 2 together with Katerina Iliopoulou, who you'll hear from shortly. A couple of housekeeping items before we start. This webinar is being recorded and will be made available afterwards. Also, we are in the same virtual room today, so transitions between speakers may take a moment. Please keep your microphones muted throughout and bear with us if we need a few seconds between presentations. We'll get there. This webinar is part of task 6.4's work on behavior change strategies for antimicrobial stewardship. The title states it clearly, from behavioral science to effective antimicrobial stewardship. And here, the word effective is doing a lot of work. We know that antimicrobial resistance is one of the major public health threats of our time, and we also know that improving how clinicians prescribe antibiotics is central to addressing it. What we've been slower to recognize is that prescribing is a behavior, and changing behavior requires understanding why people do what they do. Guidelines alone don't change practice. Education alone doesn't change practice. We need to understand the barriers, the motivation, and the context. And that's what today is about. We have three speakers who bring exactly the perspectives that we need for the session. First, our keynote speaker, Dr. Vivi Antonopoulou. Vivi is a senior research fellow at the Center for Behavioural Change at University College London. She specializes in applying behavioral science to improve decision-making and quality of care in complex healthcare systems. She's a chartered psychologist with the British Psychological Society, and Vivi will give us the foundation on how to use the COMBI model to understand behavior in context. Then, Dr. Katerina Iliopoulou, my co-leader in task 6.4. She is a healthcare researcher at the National Public Health Organization in Greece and a honorary research fellow at City St. George's University of London. She has extensive background in critical care nursing, and her research focuses on using behavioral change theories and implementation science to improve infection prevention and antimicrobial stewardship. Katerina will take us into the specifics of antimicrobial prescribing behavior. Finally, Dr. Julia Moore, Executive Director of the Center for Implementation in Toronto. Julia holds a PhD from Penn State in human development and has worked on over 100 implementation initiatives. She's known for her ability to communicate complex concepts clearly. Julia will help us bridge from understanding behavior to selecting strategies that actually work. And before starting, a quick note on format. Each presentation is 20 minutes, and we'll hold questions until the end, so we have time for proper discussion. I'll be collecting your questions in the chat throughout, so please write them as they come to you, and I'll bring the best on forward. And with that, let's begin. Vivi, over to you.
Thank you very much, Sarah. That was a great introduction, and let me share my screen. So, good afternoon, everyone. I'm very happy to be here today. I'm Vivi Antonopoulou from the Center for Behavior Change, as José has mentioned, and I'm also working for the Policy Research Unit in Behavior Social Sciences. And today I'll talk about how we can understand behavior in context using the COMBI model to design more effective interventions for complex public health challenges. So at UCL, a major part of our mission in the Center for Behavior Change is to strengthen capacity in behavior science. So we run programs ranging from introductory to advanced levels, and we've worked to equip practitioners, policy makers, and researchers with the practical skills needed to apply behavior science to real-world challenges. And we also have an MSc in behavior change. I just wanted to mention this because I will only give you a flavor of what the COMBI and the BCW, the behavior change will approach is. So if you want a bit more detailed and more bespoke and tailored content, you can come to one of our programs. So, and again, just to very briefly mention that my work in the policy research unit in behavioral social sciences, where we utilize interdisciplinary expertise to focus on the behaviors of patients, frontline healthcare professionals, service providers, and policy makers. We use a mixed methods approach and evidence synthesis. And we work very closely with the Department of Health and Social Care and other NHS, National Health Service policy partners to address complex and problems and to design system-wide interventions in healthcare systems. So I wanted to set the scene here. So why is behavior important? Because obviously implementing change to improve health almost always requires someone to do something differently. So either adopting new practices, such as an uptake of a new diagnostic test, or doing more of an existing practice, increasing referral rates, for example, or doing less of an existing practice, reducing antibiotic prescribing, or stopping or discontinuing a harmful or low-value care practice, such as the implementation of a particular practice. So what do these have in common? They're all forms of human behavior. I also wanted to give you a definition of what behavior science is. So it is a scientific discipline whose topic of study is individual human behavior, group behavior, and population behavior, and the factors that influence this. And it offers theories, frameworks, methods for understanding what drives the behavior and how best to use this to effectively change it. So in terms of the actual aim is to translate evidence into practice. So we often assume that if clinicians know the guidelines, as also José has mentioned, they will follow it. But actually, evidence practice gaps constantly show that this isn't the case. Large proportion of patients don't receive evidence-based care, and others receive low-value or unnecessary care. So this highlights that behavior is more complex than simply lack of knowledge. And actually, the reality is often far more complex. So healthcare professionals often know the guidelines, they know what the right thing is, but it can be very difficult to implement it among a lot of things that they may have going on, such as work pressures, emotional demands, competing priorities, or limited resources. So understanding these contextual influences is essential. So complex problems require complex interventions. So because behavior is influenced by a wide range of factors, emotional, social, environmental, cognitive, we need more than education alone. And effective interventions must be grounded in an understanding of the specific determinants of this of the current behavior. So in other words, the barriers and facilitators that influence the current behavior. So implementation requires changing behaviors across many roles. This can include the professionals, the support staff, commissioners, managers, policy makers, and patients and the carers. So in other words, all this changing the behavior, all these different actors within the system at different levels is an important consideration to take. And the usual approach was what is called the Islagiad principle, so which stands for it seemed like a good idea at the time, which included brainstorming solutions, then someone deciding on a solution, implementing that solution, and hoping it will work. But behavior science offers a different approach, a much more systematic approach. So before going to solutions, we are proposing to conduct what is called a behavioral diagnosis. It's similar to a medical diagnosis, so understanding the problem in more depth and identifying the barriers and enablers to the problem. Following from that, then we can match the intervention to what needs to change. So that will increase the likelihood that the solution will fit the problem. So in other words, we need to ask the following question. What do we want the person or the group of people to do? So we need to first specify the behavior. The second step would be to understand what will it take them to do that. So conduct the behavior analysis and diagnosis. Then we need to ask, how are we going to get them to do it? That includes the intervention design the intervention in a way that will match the behavioral diagnosis. And then, of course, ask, did it work? An evaluation of the intervention and its outcomes. So the behavior change intervention is what we're proposing, which is an action or activity that aims to get an individual or population to behave differently from how they would have acted without such an intervention or service. So in other words, we need to focus on the changeable, the modifiable influences on behavior, which can range from knowledge, beliefs, attitudes, and so on. Then we need to specify what behavior we want to change and what we want to see as a result of that. And then the outcome. What is the outcome that we want to evaluate? So in doing so, there's the behavior change will approach is a systematic approach. It's actually a synthesis of 19 frameworks that proposes the following systematic steps. So first, we want to understand to define the problem in behavior terms. So what behavior we're trying to change and map out the system of behaviors. Secondly, as I mentioned, to conduct the behavioral diagnosis and then consider a range of strategies that have been found to be effective for addressing the particular barriers and enablers to change. So at this point, I wanted to make an important distinction between the behaviors, the outcomes, and of course, a note on the influences. So influences is actually perhaps the easiest concept to understand is what drives the behavior and what makes it more or less likely to occur. Behaviors is a behavior is any action a person takes in response to internal or external events. Outcomes are the consequences of that behavior, and usually it's what we want to measure to assess impacts. And I want to stress that behaviors are different to outcomes. And actually, here, this will probably make things a bit more clear. So we have the tendency to think things in terms of outcomes. So we want to see a reduced infection rates, for example, or improve infection and control. But this is not a behavior. So the product, this can be the reduced infection rates, can be a product of numerous discrete behaviors. So for example, hand washing or effective use of protective clothing or cleaning the surfaces are all different behaviors which can lead to the same outcome. So a reduction in infection rates. So it is very important to understand who really needs to perform which behaviors and which behaviors we want to focus on. So going back to the behavior change wheel approach, this is the second step, is the conduct the behavioral diagnosis. So understand the behavior in context in order to identify the barriers and the enablers to change. And within that comes the COMBI model, which is a simple theory-based model to understand behavior. And the COMBI model sees these three key necessary conditions for any behavior to occur. So this is an interaction between capability, opportunity, and motivation that lead to behavior. So capability, or the psychological and physical ability that one needs to have, or a population needs to have to enact the behavior. The opportunity, the physical and social environment that enables the behavior, and motivation is the reflective and automatic mechanisms that activate or inhibit the behavior. So these three key components within the COMBI model, the capability, opportunity, and motivation, have further been divided into to six underpinning elements. So the physical capabilities actually incorporates all the physical skills, strength and stamina. The psychological capability includes all the cognitive processes such as knowledge, cognition, and interpersonal skills. Reflective motivation is about the plans, the intentions, anything that we do consciously, the beliefs or personal or professional identity that we have. Automatic motivation includes unconscious processes such as emotions, desires, habits, impulses. The physical opportunity includes triggers in the environment, prompts, also space, time, or location of the services. And the social opportunity includes the social norms, the culture, and the pressures around us in our social environment. So all these need to be in place for the behavior to occur, and all these different components interact. So this actually prompts us to think that there are many potential strategies to address these influences on behavior. So if we find during our behavior analysis, during the behavior diagnosis, that there are mostly factors that relate to the capability, we can consider interventions related to education or training. If we see that there are barriers related to opportunity, we can consider things such as environmental restructuring, or if we see that there are barriers related to motivation, there are intervention strategies such as persuasion, incentivization, or cohesion or modeling that actually can address these motivational barriers, or equally enhance the enablers that are there. And a very brief overview that the COMBI model and the three key components have actually been also mapped on to the more granular, the TDF, the Theoretical Domains Framework, which offers a much more in-depth analysis of these specific constructs into more fine-grained constructs, and actually includes 14 domains. I'm not going to go into details about this. We can take questions about this at the end. And this is the diagrammatic presentation of the behavior change wheel. As you can see, at the center of the wheel sits the COMBI model. Around it, in the yellow circle, is the Theoretical Domains Framework. But then you can also see that there are the intervention types that we can choose based on the behavioral diagnosis. There are the policy options that one can actually choose how to deliver the intervention. And also there are the behavior change techniques taxonomy, which includes 93 behavior change techniques. So the active ingredients of intervention, so the way in which an intervention can be delivered. And this, as you can see, the specific components of the COMBI model have been mapped to intervention types, as you can see here. So essentially, this represents the types of interventions that have been found to be more effective in addressing the specific barriers or enablers to behavior. Here's an example of how we have used the COMBI and the TDF models when we conduct in our analysis, in our research. So, for example, here we have extracted inductive themes in this particular example, and then we have mapped this onto the Theoretical Domains Framework and then to the COMBI model, which then enables us to provide recommendations about how to address the specific issues here. I also wanted to praise the fact that behavior does not occur in isolation, is always part of a system, as has been mentioned, as I have mentioned earlier. And there might be different behaviors that actually might facilitate or compete with each other. And this can occur between individuals or at different levels of the organization, the networks and the systems. And it is important to identify the key people and the specific behaviors within the system of behaviors that we can address. And this can actually be diagrammatically presented in a behavior systems map. Again, this is an approach that has been attracting a lot of attention recently because it can actually map out all the different behaviors and how the different relationships, how they can interact, and can enable us to find leverage, points of leverage, so points where we can direct our interventions. And a final comment about the COM-B version 2. It has become very clear to us that probably the COM-B model, although it's an interactive model and is meant to be used both for individual behaviors but also for population behaviors, it's mostly used for individual behaviors. Hence, there are now plans in our center, and Professor Robert West is actually leading this work to conduct, to devise a new COM-B version 2 model. This is work in practice, and they're working together with other colleagues from our center, such as Esther Flanagan. There were some slides recently in the social media about this and explaining the work that is being currently in progress. So I would say stay tuned, but there will be a version of this. And a final note that we have a behavior change conference that's taking place in June. So for those of you who have conducted research within this particular field, so applying behavioral science models and frameworks, we would welcome your submissions to our conference, and we would hope to see you there. Thank you very much, and I hope to take questions now or later.
Okay. Thank you. Thank you very much, Vivi, for this clear presentation. You have shown all of us the framework and the basis, and now it's time for Katerina, and Katerina is going to help us to understand how to apply this framework to AMS. Please, Katerina, the floor is yours.
Okay, thank you very much, Josera, for the introduction. Good afternoon from me. I'm very pleased that I present today in this very interesting webinar, along with experts from behavioral and implementation science. Today, I'm going to talk about why and how we explore determinants of antimicrobial prescribing behavior using behavioral science, and more specifically the COM-B model that is very nicely presented by Vivi. We are all aware of antimicrobial resistance and its impact. We understand the mortality burden, okay, the mortality burden and the economic costs. But what we may not understand is why knowledge of AMR hasn't been already translated into better prescribing practices, and why do we still see 50% of hospital antibiotic use to be inappropriate? Why haven't guidelines, education, and data solved the problem? And this is what we are going to explore together today to understand what actually drives prescribing behavior. Someone might argue that we have guidelines. Yes, we all know that guidelines exist widely, yet prescribers' adherence with them remains variable. Guidelines support decision-making through enhancing knowledge and awareness, but they may not shift attitudes or change practice. Prescribing is a behavior, and evidence-based guidelines are not particularly explicit about who needs to do what, where, and when. Therefore, we must understand what truly drives behavior, not just what doctors should do, but why they actually do what they do. So what is missing? Although there is accumulating evidence, we have systematic reviews, meta-analysis that antimicrobial stewardship practices are safe and effective. Interventions to optimize prescribing behavior are of poor quality and are not informed by a robust theoretical science framework, a behavioral science framework. Yet, context matters profoundly, as the same prescriber may behave differently, for example, in an ICU setting versus an outpatient clinic, depending on local resources, time pressure, or organizational support. And this variability reveals a critical gap. Current interventions often overlook the social and cultural factors that shape prescribing decisions, for example, cultural norms, team hierarchy, or workplace culture, the actual determinants of behavior. Therefore, a systematic approach is needed, either to design new interventions that address real barriers or to diagnose why current guidelines are not followed in our settings by using behavioral science frameworks or the COMBI model. With this slide, I would like to explain the social dimension of antibiotic prescribing behavior, because prescribing behavior is a social process, which means that prescribing, as Vivi mentioned, doesn't happen in isolation. People interact with each other. So prescribers interact with patients. Patients have expectations, requests, concerns. They interact with colleagues through informal advice, discussions, or social norms. They interact with hospital cultures and practices, with workplace hierarchies and power dynamics, and the prescribers also interact with their colleagues' prescribing patterns. Also, social influences shape prescribing choices through what others do, what others approve, through explicit or implicit expectations from the colleagues or the team, and how prescribers perceive themselves within the professional community, how they perceive the professional identity. So these kind of interactions create collective patterns. Individual prescribing decisions aggregate into the unit, into the world, into hospital patterns. And these patterns become how we do things here, the institutional culture. And culture then reinforces individual decisions. It's like a cyclical reinforcement. So the traditional approach to prescription is that it comes from clinical knowledge plus individual decision. But the behavioral science approach views the prescription as the combination of clinical knowledge, individual factors, social and team factors, system and patient factors. So why is it important to explore barriers and facilitators using behavioral science? I will repeat what Vivi said, that this is a common trap in healthcare implementation, the Islayat trap. So we see a problem, for example, inconsistent prescribing, antibiotic prescribing, and we jump straight to solutions. We design guidelines, we run education campaigns, or we launch quality improvement initiatives. But we often skip a critical step to understand why prescribers actually behave as they do right now. And the reality is that antibiotic prescribing is far more complex than individual knowledge. So the COMB reversed this approach. Instead of asking what should prescribers do, it asks what factors actually drive the current behavior, using capability, opportunity, and motivation to diagnose the real forces at play. And this approach, as Vivi said, allows us to design interventions that tackle the genuine barriers and to understand not just whether these interventions work, but why they succeed or fail. I'll give you an example. So the typical approach to prescribing problem is the clinical approach. So when identify our problem, we know that guideline exists is telling us what to do. But here we have a paradox. While prescribers know the risks and the guidelines exist, yet broad spectrum prescribing continues. And here it's where we need to shift our mindset. Instead of telling prescribers what to do, behavioral science asks something different. Why do they do what they do? What makes broad spectrum easier? What would need to change to make narrow spectrum path of least resistance? This is not about judging clinicians, it's about understanding the world. Now that we have understood somehow the complexity of antibiotic prescribing behavior, how do we design an intervention? The process, it's not linear, it's nested, which means that each stage builds on and refines on the previous one, moving from broad understanding to detailed implementation. Think of like the nested dolls you see in the slide. We start by understanding behavior, then we diagnose what's driving it, and then we identify which barriers drive these behaviors, and finally we determine the specific behavioral change techniques and strategies based on the COMBI model. Over the next few slides, I'm going to talk about the first two stages to understand the behavior and how to conduct a COMBI analysis using an antibiotic prescribing behavior example. So the first step is to identify the problem we wish to address, and this problem is context specific. So how we start, we have a clinical observation. We are seeing too many broad spectrum antibiotics in an ICU. And then we collect some local data. We identify prescribing patterns, we assess adherence with data, and then we take this data and we discuss with our team, ICU prescribers, pharmacists, nurses. And this gives us a rough context-specific understanding of the problem as the team experiences it. And then we do a literature search because we would like to understand what others have found about our problem, to identify what barriers and facilitators drive this behavior, and to see what interventions have worked elsewhere. So the literature findings inform our understanding of our local problem, as it provides us an evidence-based starting framework for what to look for and how to interpret it. So after doing all of this, we come up with this problem. Antibiotic de-escalation is not happening despite clear protocol guidance. Clinicians report uncertainty about cultural results, and fear of infection drives them to stay on broad spectrum, a combination of missing information and anxiety about safety. The next step is to define the problem in behavioral terms. Here we need to be specific about the target individual, group, or population involved in the behavior and the behavior itself. So we address the questions: what is the behavior we want to change? Where, when does the behavior occur? Who is involved in performing this behavior, and with whom? The next stage is to select target behavior. Before I describe you how we do this, I would like to remind you again that behaviors do not exist in a vacuum. They occur within the context of other behaviors, and changing the behavior depends on how different people at different roles, at different levels in organizations, networks, and systems behave. So let me show a diagram which reflects the complexity of antibiotic prescribing behavior in a hospital setting. A patient becomes unwell and goes to the hospital. An infection is suspected. Then healthcare professional communicates this to a colleague. They order diagnostic tests and collect samples. The words in red color correspond to various prescribing behaviors. And then they process samples, they take back test results, consult hospital guidelines, and discuss this again with their colleagues. Healthcare professional prescribes antibiotics, and decisions around dose, duration, and type are taken, and then they document this decision in patient notes. And then they review this decision in a timely manner, and either they stop or switch or continue antibiotics, or they order further steps. And these antibiotic prescribing behaviors are occurring within a continuous communication, a continuous documentation, and these are all the people that are involved in antibiotic prescribing behavior. So we go back to what I discussed a couple of slides before, how to select a target behavior. So we start by generating a long list of the potential behaviors that may be relevant to the problem we want to solve. So this is 7 behaviors which were identified after we searched the literature, as we discussed before, and after informing all these findings with our team. Miki and her colleagues suggest, in order to tackle all these behaviors, to focus on 1 or 2 and work intensively on this, and how to select which one we will target. So they propose to rate its behavior in terms of the impact they might have, the likelihood of change, and their spillover effect, either positive or negative, on other behaviors. So after doing this rating, we come up with this behavior: timely de-escalation of antibiotics by day 2 or 3, because it has high impact on broad spectrum use, is realistically changeable with a focused intervention, and is likely to improve other AMS interventions through positive spillover. The next step is now to specify this target behavior with behavioral terms. And this step is very important because we need to specify our behavior in appropriate detail and in context, because the more precise we define the target behavior, the sharper our COM-B analysis will be, and the more targeted our interventions will be. So this is the behavior we identified previously. And then again, we need to address the questions who, what, when, where, how often, and with whom. And we come up with the targeted behavior, which is expressed in behavioral terms: by day 2 or 3 of antibiotic therapy. ICU physicians will review each patient's regime during the ward round and de-escalate antibiotics when clinical improvement and microbiology results support it, in collaboration with the pharmacist and microbiologist, with a clear decision documented by day 3. So this is a behavior, and this is not just an abstract idea, better prescribing, but it is specific, observable action in a defined time, place, and team context. The next stage is, as Vivi described, to do a behavioral diagnosis using the COMBI model to identify the barriers and facilitators to our targeted behavior expressed with behavioral terms. And this is a systematic way to understand why the targeted behavior is as it is. I would like here to remind that because barriers and facilitators are context-specific, it's important to have this clear behavioral specification before we begin to collect behavioral insights. How we are going to collect our data to identify barriers and facilitators? There are several data collection methods published in the literature. You can use interviews, focus groups, observations, survey data, and if there are limited resources, you can undertake informal discussions. However, I would like to highlight here that it's very useful to use several data collection methods, because this kind of triangulation of data collection enriches the insights of barriers and facilitators. So we do this behavioral diagnosis and we asking the right questions based on capability, opportunity, and motivation to uncover barriers and facilitators. I'm not going to go into detail in these slides, but I would like to say that it's very important to address the right questions, because we all have as clinicians biases, so we have to be aware of this and avoid through our questions making assumptions about what we think people do or don't do in relation to the behavior. It's important that we understand the perspective of our target group. And this is my last slide. So we collected barriers and facilitators, and now we have to synthesize them to understand why people behave as they behave. So I show here in the slide one barrier and one facilitator in red and green color, corresponding to its construct of COMB. So what is the synthesis of these barriers and facilitators? Ward rounds in ICU are asked with no protected time to review antibiotics, and de-escalation is competed by other tasks. Senior consultants and unit culture favor staying broad, and clinicians fear deterioration or blame if a patient worsens after de-escalation. In contrast, clear local guidance, flowcharts, reliable access to microbiology results at 48 to 72 hours, and feedback are recognized as good de-escalation decisions. So these barriers and facilitators are real because they come from a systematic diagnosis, not from generic explanations like doctors need more education. So to sum up, prescribing is a social process embedded in context. Guidelines alone don't change behavior because social norms, team dynamics, and organizational culture shape prescribing, and effective interventions address all three. Understand the why before we intervene is very important, and behavioral diagnosis reveals what drives prescribing decisions, and the systematic specification of the behavior enables success. We have to define our target behavior precisely, and then to use the COMB model to design context-specific interventions that work in our setting. Thank you very much for your attention.
Thank you, Katerina, for your lecture. We've covered the model and the diagnosis, and now the question is, what do we do about it? So, Julia, please take it away.
Wonderful. Let me try to share my slides. Is that working? Works.
Yes. Yes.
All right. Well, the organizers did an amazing job of setting this up, because I feel like I'm going to talk about things that really build on exactly what we have talked about so far. So I am just noting that I am a little bit different. I was once a researcher, but I am no longer a researcher, and spend all of my time focusing on making things practical and relevant. And so I'm going to talk a little bit about how we do that. And I'm going to work through an example of how we can go and select strategies to make that happen. And so I'm coming from Canada, from the Center for Implementation, and we really see ourselves as a bridge between implementation research and implementation practice, which is actually often done by researchers who are trying to implement things in the process of doing their research. But that we can draw on the behavioral sciences we've talked about and some implementation science and implementation research to drive how we actually create change in the system. So the example I'm going to walk through to illustrate how we select strategies is antibiotic use in long-term care. So many years ago, about 7 years ago, I started working with a public health agency that was working on reducing antibiotic use in long-term care. And they wanted to start specifically by focusing on the overuse of antibiotics for people with urinary tract infections. So here in Canada, it had become very common for people to do regular tests for everyone inside of the long-term care home to see whether they had a UTI, a urinary tract infection. And unfortunately, there's a lot of false positives, and so people were giving antibiotics that were not necessary. Also, people were using certain ways to test for this, specifically using dipsticks, which is not as reliable as other methods. So all of this meant there was a lot of people who were getting antibiotics who really didn't need them. And so we worked together, and they used behavioral science, COM-B, the theoretical domains framework, to literally develop an entire program. And that program was initially implemented in a subset of sites. I think we had 14 at the beginning. It then got scaled to almost 100, and then to 200 long-term care homes. So it's a beautiful example of something that kind of built small, and then we iterated on what we learned as we continued to scale it up. So let me walk you through the process. So we use a process called the strategies pathway, which is really an accumulation of a lot of different processes that other people are using. And you will see aligns beautifully with what Vivi and Katerina were just talking about. We start by first exploring the thing. So what is the thing that we want to do, want to implement? We need to develop a team. We need to deeply understand the needs and gaps of all of those long-term care homes, and then clearly define the goals and outcomes that we want to achieve. And as Vivi highlighted, those are different than the thing that we are trying to implement and the behaviors we're trying to change. So they determined the outcomes they wanted to see, and then scaled it back and said, what is the thing we want to implement? And they said, we want a program based on the best available evidence to improve urinary or antibiotic use for UTIs, urinary tract infections. Once we did this work, we got into this next phase of really clearly defining who is being asked to change and what are they being asked to do differently. And I feel like this is being highlighted now in every presentation. I think this is a really commonly missed step. Something I see really often is people defining the thing. Maybe they have a guideline or a program and they're like, yes, let's go implement this. And they jump forward, sometimes to strategies. When they're really good, they jump to barriers, but they're still often missing the step of defining who is being asked to change and what are they being asked to do differently. This is an unbelievably important step because frequently people jump over it and miss people who might be pivotal to the process of implementation. In our case, they identified some leadership people that needed to do things, and then it was really staff on the units, primarily nurses. And so for those nurses, they defined what it was they need to do differently. And they identified, so we said, who needs to do something differently and what do they need to do? And they specifically identified 5 things that they wanted them to do differently, 5 practices or 5 what's that they wanted them to do differently. But we know, as Katerina highlighted, you can't just ask them to do this thing differently. We need to understand their barriers and facilitators to change. And we want to use theory to select those change strategies. And I'm going to talk about how we did that. So here is one of the examples of the 5 different what's that we ask people to do differently. What I thought was really unique about this example is 3 of the changes were like new things we wanted them to do. And 2 of the things were technically things we wanted them to stop doing. So in this case, we wanted them to stop testing people if they didn't have symptoms. So it was very common to test people even if they didn't have a symptom of a UTI. And so we wanted them to stop doing that. Another thing we wanted them to stop doing was to use the dipsticks as a testing method. So we had kind of 3 do these things and 2 things that were do not do these things. But once we had those, we knew we needed to also understand the barriers and facilitators. So like Katerina talked about, we did multiple things. We went to the literature and pulled information from the literature. We went and did interviews and conversations, sometimes formal interviews, but honestly, this wasn't a research study. So a lot of the conversations were more informal to understand people's barriers. And what we ended up doing is we ended up mapping all of those barriers and facilitators to the COM-B and to the theoretical domains framework. And so we wanted to understand what kinds of barriers and facilitators were staff having to implement these new practices. Because we got to implement this in multiple different rounds, there was actually a great opportunity to go back and revisit barriers. One of the things we see really often is that early on, if you ask people what their barriers and facilitators are before they've implemented, they can make kind of a good guess, but not necessarily realize what those barriers really are. And so as we implemented and then implemented again in more and more sites, we got to refine the list of barriers and facilitators. We ultimately took those, and because the individual long-term care homes are responsible for doing a lot of the work themselves, we wanted to make sure they could look at the barriers and see which ones may be relevant for them. So what we ended up doing is we mapped all those barriers to the COM-B in the theoretical domains framework, and then we distilled them down, reorganized them, and highlighted 21 common barriers that we saw across different sites and settings. And we created a resource, I'll show you in a little bit, that allows sites to go in and say, hey, this is a barrier for our site or setting. That one's probably not a barrier for us, or this one seems really, really important. And so it doesn't mean that's the full list of barriers. There could be unique ones that come up, but we at least found the 21 that came up really frequently. And we specifically made sure they didn't just focus on knowledge and skills. I feel like this is kind of being alluded to many times today, but people love to go to strategies that they are comfortable with. We joke that people love the train and pray strategy for implementing things, essentially to train people or educate them to do something new and pray that they're going to change. But we know that things like education only work if knowledge and skills are our main barriers. And as Katerina pointed out, in the world of antimicrobial stewardship, there are a lot more barriers than just education. So we really wanted to help push people to think about some of these other barriers that maybe they weren't first thinking about. Especially, I think a big one that comes up a lot in this work is this belief about a consequence. What if a bad thing happens if we don't give someone antibiotics who needs it? So we did all this work. We found these 21 barriers. And then we wanted to go and select strategies to support people to actually address those barriers and facilitators. And so I'm going to see if this works. Hold on. I'm not sure. Can you see my screen on the tool? Perfect. Okay. So What we then did is we've developed this tool building on the incredible work of the group in the UK on barriers and on COM-B and TDF, where you can go in and say, okay, I want to select strategies to address these barriers and facilitators. So we would go in, click on some of these different strategies or TDF and say, you know, beliefs about consequences is a major challenge for our specific context. You can go in, you can see all of these different functions that have been highlighted: educating, training, modeling, persuading, and it highlights the ones that the group in the UK has said, hey, these are the ones that are most relevant to address beliefs about consequences. So we could then say, ooh, I think that persuading or maybe modeling is something that we really want to explore. You can go and click on modeling and a list of strategies will show up. As you will see, these strategies are not brand new, unexpected things. These are strategies that people commonly use, in fact, in our change initiatives all the time. But they're not necessarily the ones that we default to. And so it helps push us to think differently about other additional strategies that we could be using to push the needle and kind of really address the barriers and facilitators we've identified. So we could do things like modeling the change, providing supervision, shadowing experts, visiting other sites. But you might say, actually, I think persuasion is really important in this work, which it is. And so you could go and say, let me go check out what those persuasion strategies are. And again, it'll give you a list of different strategies. Lots of these are things that people have used: champions, engaging leaders, identifying early adopters. And so there's a lot of different things here. I do want to highlight all strategies are not relevant for all contexts. Let's say this example of antibiotics in long-term care. Public demand, mass media, probably not the right thing to address these kinds of barriers. So work is needed to kind of navigate, hey, which of these strategies is going to be relevant for us and our context? I want to say one small note. We call them change strategies because in our experience with practitioners, they prefer that term. But in the literature, they are called implementation strategies. And so you can find lots of literature on implementation strategies in the literature. What's also great about the way that this COM-B TDF to the functions is set up is that you might pick a couple strategies for persuasion and realize that they can actually address a lot of different barriers you might have identified. So if I jump back here, I can share with you that for this work, we ultimately identified, or the group identified, 9 different strategies in 3 different categories. They had 4 strategies about increasing buy-in and support. And they were very strategic in putting these strategies above increasing knowledge and skills. Knowledge and skills were absolutely necessary, but they recognized there were some more emotional pieces, there were some more belief-based pieces that needed to be addressed first. And so they pulled increased buy-in and support, like involving local influencers, generating buy-in, align policies and procedures, reviewing how residents' symptoms are documented and communicated. Then they had a couple strategies related to knowledge and skills, and then 2 strategies related to monitoring and feedback. And audit and feedback are a very common practice in long-term care in this area, and so this was kind of very easy to embed in current practice. I want to show you also the website where they have a lot of these different pieces to highlight for the teams how they can do this work. Teams can get some central support from Public Health Ontario that built this program, but a lot of the information is here. So why was the program developed? Here are the 5 key practices. There's an implementation guide that people can download, and lots of information. Then they can jump into starting by assessing what they need to do. There's a practice change questionnaire to understand current practices. They can think about considerations for whether they're ready or not, and look at getting an implementation team together. Then they get into assessing the barriers and facilitators. And so this is the worksheet that lists those 21 common barriers that were identified. Here's the core strategies that I just mentioned and highlighted, and a way to create an action plan. And so more information about the strategies is here, including lots of resources. So if you pick delivering classroom education, there's lots of resources that people could go and use. And then they have plans for actually implementing it and going and having an implementation checklist with all the resources at the end. And so I wanted to highlight how they tried to make this really accessible to the people who actually have to go and implement it, but might never be trained in the science of like behavioral science or implementation science, but are literally responsible for going to implement this. And so one of the things that you might have noticed is there were a few pieces embedded in there that weren't actually highlighted in the previous strategies pathway. Things like building an implementation team, assessing readiness. And so I wanted to highlight that the way that we see implementation science is that first you need to do this behavioral science work of building the program that you're going to implement, right? So understanding the who's and the what's, the barriers and facilitators, and picking those strategies. But once that work is done, to actually go and implement something or spread or scale something, there are many other steps that are needed. For example, identifying and building out supports, figuring out who is on your implementation team, who is on the local implementation team, what are they doing, what are their roles? Figuring out how we assess and address context and readiness. There's incredible research and actually a great new paper that just came out that showed that sites that were not ready are much less likely to be successful at implementing. People used to say the old number I heard people cite over and over was 2/3 of sites do not successfully implement because they aren't ready. But there's a new paper that just came out that highlighted that for sites that were not ready, so not all sites, but for those that were not ready, over 90% of them ultimately were not successful at implementing. And so we need to look at what is a site's readiness and what can we do to build readiness before we move forward with implementation. We also want to do things like planning for adaptations, planning for implementation, planning for sustainability, figuring out how we can operationalize these plans and kind of do cycles of improvement as we go, and make sure that we're evaluating to make sure that things are actually working. You will notice that while the strategies pathway is somewhat linear and we typically rotate back and forth, this is an extremely non-linear pathway because the process of implementing is very non-linear. And so we kind of have to jump all over the place as we plan for implementation and think through these different pieces. You might notice that a lot of these pieces were baked into that example that I gave you. So you can see how they talked about readiness, implementation teams, implementation plans directly inside of the way that they presented the program to sites. So hopefully that gives you a little bit of a flavor of some of the ways that you can select strategies and build out implementation plans. I have all these references and I think slides will be shared, and I wanted to flag, I included that program website here at the bottom if anyone wants to go and check that out. And you can also find the strategies tool, which is freely available for anyone who wants to pick strategies right here. Like the ComB group, we have a new version of the strategies tool that will be coming out in early mid 2026. And we are going to have not only the TDF ComB, but also contextual factors that you can address in the new version of the strategies tool. So it'll be both that individual factors and contextual level factors at the setting and the system level that we're building in. And so with that, I want to say a huge thank you and a super thank you. I'm very impressed by the organizers for how well they set up the building of these different sessions.
Thank you very much, Julia, for this interesting talk. It was the last step. What do we do? What we did before with the diagnosis, and thank you very much for explaining so clearly this intersection between behavior change and implementation. And if someone has a question, can write in the chat, and we will compile. And we can select some of them. But while you think of questions, I have some, and for Vivi, one concept that I learned today, and I like it very much, is the system, the behavior system mapping. And I think that that doing that at the beginning, I think it may be interesting, and it can help to prioritize. And I think that's an exercise. Is there any tool to facilitate behavior system mapping, or how do we how can we accomplish that?
Yeah, thank you very much. This is actually something that me and colleagues within the CBC, the Center for Behavior Change, we have been working together because we realized there's a need for a tool, and this is a new approach. Actually, it builds on the existing frameworks and theories. So we're using everything we know about the COM-B and behavior science theory, and now this complements it with the systems thinking theory. So it combines behavior science and system thinking together. There are some tools that I could share, although this is an approach, as I said, that it's mostly the systems thinking that I think others have been developing, but the behavior systems mapping, it's a thing that we have developed in the CBC, and we offer a course on that. But we don't have a tool yet, or something that I can share. There are some papers that have been written by members of our team, and I'm also working on a paper myself on this. But I can send you some resources around that.
Thank you very much. I'm a clinician. I'm in charge. I mean, I coordinate an antimicrobial stewardship team. We from the Jump Right to have surveyed AMS teams in several European countries, and we found out what we knew is that the AMS teams are very under-resourced, and there is a very little knowledge on behavior science. Imagine that you have convinced us that this is the way to go. I'm convinced. How do we make behavior change accessible to these teams that are spread all over the healthcare? How do we make it?
Is that a question for me?
Yeah, it's for,
I mean, in the UK at least, again, there's a huge program of work called the BR UK, Behavior Science UK, which aims actually to build capacity of behavior science in across the government, the national government, the local government, and also to enable lone behavior scientists that are in public health teams to actually spread, as you said, the word about behavior science and how important it is. So this is something that in the UK at least is being sort of, I guess, addressed in that way. So we're putting efforts together, all behavior scientists in this program to develop capacity. I think that's something perhaps in the European sort of countries can work more around. I'm not sure whether there are such efforts or behavior science teams in other national or local governments, but I think that's something that actually needs to be highlighted and needs to be supported, because it is important to have behavior science, I think, in a lot of, I guess, clinical practice settings. Yeah, I don't know if Katerina or Jill would like to comment on this around sort of different countries and their approaches.
Yeah, I can add. So we work very internationally, and one of the things that we see over and over is that I think it's happening at a lot of levels. So like there are countries where it's happening nationally. I think that's not the norm. I think that's the exception right now. One of the things we're seeing is organizations who are stepping up and saying, we want to implement things better. We're seeing more and more funding agencies saying, hey, we want to be funding work that is related to implementation. And so we need to be infusing behavioral science, implementation science, things like that. Some of those are federal agencies. Some of those are research agencies, but also a lot of philanthropic funders, a lot of like nonprofits are trying to embed this into the way that they're doing things. A lot of healthcare organizations. And one of the groups that we are seeing readily adopting behavioral science and implementation science are the people who are the quality improvement professionals embedded inside of systems. I think that these are people who are tasked with implementing change. They know it is very, very hard to do. They are looking for more answers. And as long as we tell them, you can continue to use the methods that you use and infuse implementation science, behavioral science into what they're doing, we have had a lot of openness and receptivity to that. And so I think that there's a lot of different ways I think it's happening globally, but those are some of the things that we have been seeing. And I kind of think you have to start with a small group and build it out from there if it's very new.
Just I wanted to add on this, the experience from Greece and the experience I have in working with the European Implementation Collaborative. They undertook a survey mapping to see in Europe what is the research, the capacity in research, in education, in implementation science. There is a variability. We see this capacity to be higher in Switzerland, in Netherlands, in Portugal. Portugal actually changed and started to work at the national level on implementation science after COVID-19. In Greece now, I think what is needed is to raise awareness about implementation science, because it is what clinicians are doing in everyday practice, but they don't know that this is how it is called. So yes, it is very important for my country to build this capacity and to learn from how this implementation science at the national, local, or governmental level has started to work.
Thank you. And I think this is very interesting, because if we want, I mean, this is something that we have to think about in the EU GenRI on behavior changes, as how can we contribute to increase capacity on behavior change, and you have presented complementary strategies, no? And I think this is very interesting, and also the mapping that Katerina showed us. And what do you think of education and training of healthcare professionals in behavior change? How would you do it? I mean, what do you think? How can we increase their knowledge? Do you think they are? How would you do it? General healthcare professionals, do they need to be educated in behavior change or implementation, or just the quality improvement people?
I mean, I think it's variable. Our experience would be, so we train thousands of people around the world in this, and I would say a portion of them are clinicians. I would say typically they're clinicians who are responsible for quite a few things. Like it's not a primary care doctor who is just looking to do this for themselves, but I would say that they are people who are leads or supporting teams, and they are trying to implement changes. I think so many people in systems are trying to implement changes, and we've seen a huge uptake around the world. And I think that, as we talked about, education and training is essential for this. It is necessary, but not sufficient to get them on board to do the complexity of the reality of this work. But I think it is a great starting place. And I think that there's a lot of openness right now at a time when people recognize there's a lot of change in a lot of systems, and people are responsible for making change, and they find that very, very hard to do. And so I think we're finding a lot of receptivity. It looks like Vivi might have similar thoughts.
Yeah, exactly. Just to build on what Julia, you're saying, yeah, we've seen, obviously, we offer a lot of courses, as I mentioned at the start of the presentation, and we've seen so many people coming from all sort of domains and different roles, different levels within their organization. So clearly, this is something that's attracting a lot of attention. There is a momentum, I guess, for behavior science and implementation science at the moment, because it has been, I guess, people have realized that we need to actually invest in the behaviors and the implementation side of things to actually make these interventions effective, because there's been so many trials, so many things that have tried to do certain things but have not been as effective as they could have been, because behavior science are not informed by behavior science or implementation science. So I think there's a recognition of this. So people are looking for training opportunities, and obviously coming to webinars such as this. So in fact, I think also the WHO has included behavior science as a key component now for designing interventions. So this is a major recognition of the importance of behavior science and implementation science. So there is, as I mentioned, a momentum on this, and yeah, it just needs to, we all need to spread the word, I suppose, and people will keep coming to such webinars, but also I guess the organizations or the people who are making such decisions in the organization, they can also organize local initiatives for their organizations and their people, including all sorts of different levels of professionals within their organization.
Yeah. Katerina, please.
I would like to ask Vivi and Julia a question which I find it very important somehow to raise in this webinar regarding to antibiotic prescribing. I know that in the UK what I'm going to ask exists, but I would like also Julia to tell me whether she applied this in the example you showed us, the involvement of patient and public in antibiotic prescribing interventions, because this is something that we have discussed with Josera in the within the working package, the subtask we have, and I would like you to tell us at which stage they should start to be involved, from the beginning, somewhere in the middle. Thank you.
I can jump in, and I can also use this to answer one of the questions in the chat from Somba. So I'll be honest, the example I gave you initially did not include much patient and public involvement. It was started in 2018 by a government organization, and I think that was not, they were not there yet, if you know what I mean. But I think the reality of implementation is that it is never once and done. And I think that, so I have kind of two answers. So in situations like that, which kind of answers this question, which is this only pre-implementation work? And the answer is no. 50% of the people who come to us to ask us for help, right? So like we do training and then we partner with people on initiatives. 50% of the people who are showing up to say, hey, can you help us with this, have already been implementing and are either failing or not getting what they want, and are then trying to embed behavioral science and implementation science into what they're doing. And so I actually think sometimes there's huge advantages of that, because you can get better data on barriers and facilitators if people are actively implementing than if you haven't even started. That being said, the dream is that you start doing this from the beginning, and the dream is that you start engaging those who are impacted by this work right from the beginning, whether that includes the patients, family members, other organizations. There's a lot of people who are sometimes connected or interested in the potential work and outcomes, and engaging them right from the beginning in very thoughtful and strategic ways, I think is really essential to making high quality implementation work.
So, and just add to this that in our units, in the policy research unit that I mentioned, that I work for, we actually have a dedicated public and patient involvement and engagement group that is actually advising us from the very start of the project. So even the research questions that we're asking, whether this actually resonates with the public until the very last stage, the dissemination. So they're helping us to disseminate the findings. So this is a key component and a key requirement, I would say, for all the NIHR-funded projects. So the National Institute of Health and Care Research requires that all projects have a PPI group embedded in the projects.
Okay, thank you. Thank you, Vivi.
Thank you. Let's go for some questions in the chat also.
Yeah.
Emmanuel asks if the combi model can be also applied for outpatient care, primary care in antibiotic prescribing.
My experience is yes,
Yeah.
absolutely. We've seen it lots in primary care. My warning is, my experience is implementation in primary care is one level more challenging than implementation in an organizational setting like a hospital. I think that there's a lot more diversity in what people are doing once you get into primary care, and people have a lot more freedom, at least in many of the countries we've worked in primary care with less oversight. And so I think that it is absolutely possible. I think that creating change in primary care, though, is just one level more challenging sometimes because you don't have all the structures around people that you do, say, in a hospital or another type of organization.
Mm-hmm.
Thank you. Wajob asks, it's a long comment, and I think this represents some of the barriers, entry barriers to behavior change for clinicians. He appreciates the systematic approach, but he also underscores the complexity of the system. How can it be made less complex? For example, he asks, okay, we identify determinants, but there are so many. How do we prioritize? No, so that's his question or her question. I don't know.
Yeah. Sorry.
Okay.
Go ahead, Katerina.
Just, I would like to share my experience from doing an implementation science project in an ICU setting. Although it's more isolated, however, the complexity of patients and other challenges didn't make this initiative very straightforward. I would start, from my experience, I would start by building a good team, by identifying champions in the setting that you want to change practices, to have a sense of the context readiness, as Julia said. I think this is a good beginning because having a dedicated and committed team is a very good start to face these complexities. This is just my experience and advice from my experience.
Absolutely. And a quick comment from me, I posted in the chat, there's what we call the APPEASE criteria. That's something actually I had in my presentation, but I removed it because in the interest of time. So again, this is a framework that they stand for affordability, practicability, equity. I can't remember all the initials, but there are many different factors that can actually play a role in prioritizing which behaviors or which influences we need to address. And this can ideally be done, as Katerina mentioned, with the stakeholders. So essentially, having done all the analysis and identifying a lot of different influences on behavior, then we can discuss with the stakeholders that we want to involve or design the intervention for, which one, and use, as I said, the APPEASE criteria. So is this something, is it practical? Is it affordable? Is it equitable? Is it, what's the spillovers or unintended consequences? That's something, again, to bear in mind. So the APPEASE framework, I can include that when I share the slides. It is really useful to help us prioritize what to address, because obviously it is impossible and we don't have the resources and the budget to address everything. So prioritization is good, and this framework can help us do that.
Thank you very much. We are just about the time, and I would like to ask the audience to go through the chat because Julia has shared a very interesting course that before the session ends, so they can access the link. It's a free online course, self-paced, on concepts on implementation. And Vivi also has shared with us about the National UK Behaviour Research Unit. And I think this is valuable information. And if you please, before leaving the session, you can access. And I don't know if Katerina, as the Task 6.4 co-lead and Alma of this webinar, and do you want to say anything to close the webinar, Katerina?
Yes, I would like first to thank all the participants for their presence here. And I'm very excited to take part in the EU JAMRAI in the next year, 2026. I think, Josera, you should talk about a bit about the toolkit. Just I want to say that we are going to develop with a group of partners an online sustainable training program on behavioral science, on COMBI, using a co-design production development. So this is going to be very excited because with this way, behavioral science will be, the knowledge on behavioral science will be disseminated within EU member states. But Josera also is going to do something very interesting in relation to developing tools for those who are not behavioral scientists.
Yeah, we are planning to create an AI-based assistant for AMS teams, and we're working on that. We are learning which are the best models, and we hope to show you something next year. And as Katerina said, I would like to thank Vivi, Julia, and you, because for me, this, as an audience, not as a moderator, but as an audience, it's been a very interesting webinar. And as Julia pointed out, I mean, we have followed a route from the beginning, the framework, diagnosis, and the strategy. And I think that for me, at least, it's been very interesting. Thank you very much for your kindness and your presentations. And if you wish, we say just bye-bye to everybody. And let's make it change, okay?
Yes. Thank you very much. Thank you. Bye.
Bye-bye.